Onc Live Insights is a video editorial program produced by Onc Live.
My practice is focused on adult patients with non-malignant hematologic disease. I care for a large number of patients with iron-related disorders, which would include sickle cell disease predominantly, as well as patients with low-grade myelodysplasia, Diamond-Blackfan anemia, and other diseases that occasionally need transfusion therapy. Sickle cell disease accounts for a large percentage of my practice, and I take care of about 300 adults with that disease, of which about a third have some degree of iron overload that would be considered for iron chelation therapy. Beyond that, I care for patients with hemochromatosis and other iron-related disorders, and as well as patients that have anemias that require transfusions intermittently. There are generally no symptoms of iron overload that occur in the short term. This is generally a long-term problem that occurs with heavy use of transfusions. The consequences of that are often seen first in laboratory testing, which would include abnormal iron studies, increasing ferritin, and increasing iron transferrin saturation. When you do start seeing clinical symptoms, however, then the problems are often much more severe. The most common problem that we see is evidence of liver dysfunction, abnormal liver problems. Besides the laboratory findings, you can start seeing hepatomegaly and large liver, or other evidence of liver dysfunction, increased bilirubin, for example, and jaundice. An underappreciated problem from iron overload with liver disease, I think, is right upper quadrant pain that can occur with people that are heavily iron overloaded, and I think this sometimes gets misdiagnosed as other causes of pain rather than iron overload. My practice involves adult patients with sickle cell disease, generally from age 18 and beyond. The oldest patient we've cared for with sickle cell disease was in her 80s. We have a large number of older patients with the disease as well. The patients are often transitioned from the pediatric program. There are 2 pediatric programs here in St. Louis that send patients to us for care, and the transition is not always smooth. Sometimes there's gaps in transition where the patients don't come right over. They may get lost to follow-up, their care may get fragmented, or they may end up at other institutions for a period of time. So we try to improve on that all the time by increasing the contact between the pediatric program and the adult program. The transitions are always difficult. It's not just a transfer from one physician to another with a simple handoff. There's much more involved in that to be able to ensure continuity of care, including transfusion management and chelation therapy. The patients that I care for are all adults. Most of their problems that require medical attention do revolve around pain management, and that still is one of the major focus of taking care of patients with sickle cell disease. But part of that often does include transfusion therapy as well. We try to give guidelines to patients for their medical management and their pain management. Every patient is different, though. They require different therapies, different doses. You need to take care of patients on an individual basis. I think it's important to realize that the pain management in adults, I think, is much more complicated because there are more causes of pain that may be underappreciated. So, for example, sometimes opioid dependence becomes a problem in pain management for adult sickle cell patients. Chronic bone disease from bone infarcts or avascular necrosis becomes a more serious problem in the adults with sickle cell disease, along with the vaso-occlusive crisis that can occur, certainly, and other causes of pain that may be underappreciated, like related to iron overload in the liver or other organ system dysfunction, may all give rise to some pain as part of the problems. So I think it's difficult to sort out pain in adults, and that's something I do try to focus on.